Welcome to our video on valvular heart disease. Let's begin. Here is a table summarizing some key points of each of the conditions we will cover. And notice that almost all of the valvular heart conditions can present very similarly in regards to their clinical features. Knowing this, we must focus in on key differentiating features of the murmurs each condition produces and other distinguishing findings to differentiate between all of these valvular disorders. Although infective and non-infective endocarditis can cause valvular disease, these will be covered in a separate presentation. Tricuspid regurgitation is defined by the inadequate closure of the tricuspid valve during systole, leading to regurgitant blood flow across the valve. This condition is largely secondary to another cause, such as due to tricuspid annular dilation and/or leaflet tethering in the setting of increased right ventricular pressure and/or volume overload, and much less often due to primary disorders of the valve apparatus. As previously mentioned, tricuspid regurgitation is defined by an incompetent tricuspid valve and backflow of blood into the right atrium during systole. This backflow goes into a very compliant right atrium and most often does not cause further hemodynamic changes. However, if tricuspid regurgitation is severe enough, right atrial and venous pressures can rise and cause congestion, leading to manifestations of right heart failure. Elevated central venous pressures have been shown to lead to renal failure, as increased renal venous pressure results in decreased glomerular filtration rate. Here we have an illustration of the direction of flow of blood during systole in the setting of tricuspid regurgitation. As you can see, as the heart contracts, the insufficient closure of tricuspid valve allows for inappropriate backflow of blood across the valvular annulus into the right atrium. Due to the fact that most common causes of tricuspid regurgitation are secondary to another condition, risk factors would include any condition that may increase right ventricular pressure and/or volume. These may include, but not limited to, heart failure, mitral stenosis and regurgitation, carcinoid syndrome, and primary pulmonary disease, leading to cor pulmonale. Risk factors for primary tricuspid regurgitation include those with pacemaker or implantable cardiac defibrillator placement, leading to direct damage, IV drug use, increasing susceptibility to infective carditis, rheumatic disease, a history of chest wall trauma, or Epstein's anomaly. Basically, conditions that directly affect the valve itself. This is how Epstein's anomaly looks like grossly, as well as on ultrasound. Notice that most of the right ventricle has atrialized due to downward displacement of tricuspid valve from its normal position. This leaves only some part of the right ventricle to be functional. So why might liver function tests be elevated in a patient with tricuspid regurgitation? While there are a handful of possible lab test derangements in this condition, in severe tricuspid regurgitation, elevated liver function tests such as AST and ALT, as well as hyperbilirubinemia, may be present due to the progression of right-sided cardiac congestion. The decrease in forward movement of blood flow from right side of the heart to the pulmonary vasculature would lead to backflow of blood into the superior vena cava and congestion of blood flow within the liver. This condition is usually asymptomatic, but signs of right ventricular failure, including ascites, hepatomegaly, JVD, and edema may be present. As we mentioned on previous slides, these signs are due to venous congestion leading to a fluid overloaded state. Physical exam reveals an inspiratory S3 sound, which is an S3 heart sound that is intensified upon inspiration. Jugular venous pressure monitoring may show a prominent V wave with rapid Y descent. The murmur in tricuspid regurgitation would likely be a blowing holosystolic murmur heard at the left lower sternal border. Here is an image showing jugular venous distension. Hopefully you can appreciate the prominent jugular veins right here. This is seen in tricuspid regurgitation because of backflow of blood into the venous circulation. Diagnosis is confirmed by echocardiogram, which can demonstrate dilation of the right atrium, and right ventricle are usually present as well. This will be accompanied by backflow of blood on Doppler across the incompetent valve. Here's an image showing how tricuspid regurgitation looks like in an echocardiogram. Hopefully you can appreciate the regurgitant blood flow on Doppler via tricuspid valve right here. So why may an ablation for atrial flutter lead to tricuspid regurgitation? Tricuspid regurgitation on rare occasions may be caused by iatrogenic injury during radiofrequency ablation procedure due to the proximity to the cavo-tricuspid isthmus, a common target site of ablation procedures due to the fact that it may give rise to flutter waves. Ablations for atrial flutter often target the isthmus between the IVC and the tricuspid annulus. All invasive procedures come with a small risk of causing valvular damage. In order to treat tricuspid regurgitation, the underlying cause must first be addressed. Symptoms of volume overload can be treated safely with diuretics. Surgical valve replacement is indicated for symptomatic patients with severe primary disease that is resistant to medical therapy, only if right ventricular dysfunction is absent. So let's read a question. A 36-year-old man comes to the physician due to shortness of breath and bilateral leg swelling for the last week. He has had high fevers for 2 weeks. He has been using heroin since the age of 20. His vital signs include a temperature of 38 degrees Celsius, a blood pressure of 110/80, heart rate of 110, respiratory rate of 15. The physical exam reveals track marks on both antecubital fossa along with bilateral pitting edema up to the knees. Cardiac auscultation reveals S3 heart sounds and a blowing holosystolic murmur at the left lateral sternal border. Which of the following is the next best step in the management of this patient? A. Echocardiography. B. Right heart catheterization. C. Chest X-ray. Or D. Chest CT scan. This patient has had high fevers for 2 weeks, and now he presents with shortness of breath and bilateral leg swelling for the last week. Considering that he is a chronic heroin user, he'd likely introduce bacteria into his venous blood. The first heart valve that the venous blood comes into contact with is the tricuspid valve. Therefore, bacteria in the blood caused infective endocarditis of the tricuspid valve. Infective endocarditis of the tricuspid valve, on the other hand, resulted in tricuspid regurgitation and right heart failure. Right heart failure and volume overload are evidenced by S3 heart sound and the bilateral pitting edema. Tricuspid regurgitation, on the other hand, is evidenced by the blowing holosystolic murmur at the left lateral sternal border. The best next test to diagnose any valvular abnormality, including tricuspid regurgitation, is the echocardiography. Therefore, the best answer is A. Here is a slide reminding us of the diagnosis of tricuspid regurgitation. Let's discuss why the other options are incorrect. Option B, right heart catheterization, is incorrect because although it can definitively diagnose the tricuspid regurgitation, it is an invasive procedure and should be avoided as the initial test. Options C and D are incorrect because although chest X-ray and chest CT can identify the dilated right atrium and ventricle, these imaging modalities are not sensitive enough to definitively diagnose the tricuspid regurgitation. And that concludes our lecture on tricuspid regurgitation.